Thank you, Prof, for the introduction. As Prof mentioned, I'm a sixth-year medical student from Amsterdam, and I did a research project over here. And the research project is about patients' understanding after counseling. And the underlying question is, do patients have a clue? So, in introduction, it's not different than any other presentation. First, some background, methods, and results, and finalize with the discussion and conclusion. Anybody who has worked on the onco-gynae firm knows that the counseling on Wednesday is a really important day, one of the most hectic days. It's where all newly diagnosed patients will be discussed, and after the council meeting with the multidisciplinary meeting, the patients will get their final diagnosis, and the proposed treatment plan will be discussed with them. And the goal of this counseling is to give information to enhance their understanding of their disease and about the proposed treatment plan, and to finally get to an informed and a shared decision with the patient. Everyone who has done this counseling knows that this is can quite be a struggle, and that this goal is not always reached. So what we know is that limited understanding can lead to failing treatment adherence. There hasn't been a Wednesday where I was sitting at the meeting and didn't hear about a patient who failed to follow up because she didn't understand what was expected from her. Comes back a year or two later with a progressed disease and a far worse outcome. What we know about limited understanding is that it has to do with cognitive factors like education, health literacy, and language barriers, but also it has to do with interpersonal dynamics like socioeconomic status and patient-physician interaction. Patient-physician interaction is maybe not a term everybody has heard, but it's how confident a patient is in communicating with his or her physician. So the key objective of this study is to gain insight in potential predictors of patients' understanding. And we formulated two research questions. One is to what extent do patients have understanding of their disease and proposed treatment plan after counseling? And two is to what extent are patient characteristics associated with patients' understanding? And the last one is to maybe find patient characteristics that could be predictors for, so that we can predict which patients are the most vulnerable to miss the boat. So the study followed a cross-sectional study design, and the inclusion criteria were newly diagnosed patients who were English, Afrikaans, or Xhosa speaking, and were older than 18. What we did is we made a questionnaire to assess patient characteristics, but also to assess their knowledge. We used translators we also translated the questionnaire so we could also include Afrikaans and Xhosa speaking patients, and the questionnaire was held verbally so that also illiterate patients could also be included in this study. So the following patient characteristics were taken into account: background characteristics, age, native language, and educational level. Furthermore, socioeconomic status. We assessed that by using an asset-based measure. So that means that we didn't ask them how much they earned or what their income was, but what they possessed. And we tried to get three different categories: low, middle, and high. And because we were only looking at relative socioeconomic status, we wanted groups that were evenly sized. Furthermore, we looked at health literacy using the short assessment of health literacy score. And out of that score, you'll get patients will be defined as having adequate health literacy or inadequate health literacy. And finally, patient-physician interaction score was from 5 to 25, and how higher the score, how more confident they were in their ability with communicating with a physician. So our dependent variable was knowledge, and we assessed that by using 12 items in 4 domains. 3 items about the patient's malignancy, 4 items about the treatment plan, 3 items about follow-up, and 2 about accepting treatment. The questions were all, or they were statements that could be answered with correct, incorrect, or I don't know, or they were multiple choice questions. For each question that a patient had correct, they received 1 point. As an example of the questions is about patient malignancy, what's the origin of the disease? Is that in the cervix, uterus, vagina, or the ovaries? Treatment plan, the treatment will be surgery, chemotherapy, radiotherapy, or a combination. Follow-up, after treatment, regular checkups are necessary, correct, incorrect, or I don't know. And accepting treatment, I'm allowed to decline the proposed treatment plan. Again, correct, incorrect, or I don't know. Fairly simple questions, you would say. So to answer the first research question, to what extent do patients have understanding of their disease and proposed treatment plan, we dichotomized knowledge in patients with adequate knowledge and not adequate knowledge. A score of 8 and higher would be considered as adequate, and lower than an 8 as inadequate. For research question number 2, to what extent are certain patient characteristics associated with patients' understanding, we used a bit more difficult statistics. First, we analyzed the proportional differences using the Fisher's exact test. So what we looked, for example, we looked in the different native language groups and analyzed if the proportion of patients with adequate knowledge was different in the different groups. And in the variables that were statistically significant, it showed statistically significant proportional difference. We put them in a multivariable logistic regression, and that's to see what the association is. So if we look at the patient characteristics, we see that the mean age was 48. Most of the patients were Afrikaans speaking, what you also expect in this population, followed by Xhosa and English. And the education level was fairly low, 67% scored low, and with low we mean that they didn't even finish primary school. As mentioned, the socioeconomic status was in an evenly sized group, and the health literacy was 29. Only 29 patients scored as adequate. While if we look at the patient-physician interaction score, that was actually quite high, so our population was quite confident in their communication with the physician. So if we look at our dependent variable, we see that from the 75 patients, only 40% scored as adequate and 60% as inadequate. And we see also that the mean score is of the population is 7 with a range from 0 to 12. That means also that there were a couple of patients who scored as 0. So they had none of the questions correct. So if we look at the proportional differences, we see for knowledge and the different age groups, health literacy groups, and the patient-physician interaction groups, that there was no statistically significant difference. But what's more important is if we look at the different native language, educational level, and socioeconomic status, because in these groups we see statistical difference. And I only want to elaborate quickly on this score. If we look at the Xhosa speaking patients, only 14 scored as having an adequate knowledge. So we put these 3 variables into a multivariable logistic regression to test the association between them and knowledge. And what we see is that we can get a explained variation of 43%. So that means that the chances on having adequate knowledge could be explained for 43% by only these 3 variables. So what this table shows is actually the odds ratios. And to have an odds ratio, you have to have a reference value. So we use for native language also as a reference. And then we see that Afrikaans has a patient who speaks Afrikaans is 18 times more likely to have adequate knowledge. while English is four times more likely to have adequate knowledge, while this one is not statistically not significant. If we look at educational level, we see that somebody with a high educational level is 9 times more likely to have adequate knowledge, and intermediate is not statistically significant compared to the reference value. Socioeconomic status, again, low and middle, statistically no significant difference, but between low and high, we see that high is 6 times more likely to have adequate knowledge. So what we see is that overall 40% of our population has adequate knowledge, and the biggest, I think, standout is that only 14% of our also speaking patients has adequate knowledge. What we can say is that in this study, it's a social study, and that it has a really high explained variation, especially if you consider that we didn't take any family matters or other external factors into account. What I didn't show in the statistical analysis, but what came out of the results, is that native language was the biggest predictor for having adequate knowledge. Now we can say that patients with low socioeconomic status, with low education level, and also speaking, are the most vulnerable patients. So what? As I said before, limited understanding leads to could lead to failing treatment adherence. But the second thing is what I was thinking while making this presentation, also writing the pieces. If we are asking informed consent, how much consent are we getting, and how informed is this consent? So what now? I think contributors to the solution could be the use of visual aids or translation applications. What we also discussed, and what's quite interesting, is maybe a peer-to-peer system where survivors could explain to people who are getting the treatment what's going to happen, what they could expect. But maybe a more long-lasting and more difficult solution would be to have trained translators, trained interpreters that could help on this Wednesday. And I understand it's really difficult, but also more integrated in the curriculum, so that doctors could communicate properly with their patients. And I have to say it's one of the most difficult things I've seen here in South Africa also. And I'm also quite proud that one of the translators that helped me is now engaged into revising this curriculum to get also more on the foreground. So some strengths about this study is that the use of translators who were also medical students, so they understood the concept and the context of the counseling and of the questionnaire. And the questionnaires were conducted verbally, so also illiterate patients were included. And it's a good reflection of the population that we have. Some limitations. The questions and the cutoff points are arbitrarily chosen. They were made by an expert panel of gynecologists who are specialized in oncology. But however, it's arbitrarily chosen. There is no evidence-based knowledge list for these specific patients, so there wasn't a better solution. And it also covered the 4 domains that we thought were important. Another thing is, because the limited time of the study, there was no follow-up, so we don't know what knowledge really does on treatment adherence in these patients. What would also be good to know is what does having adequate knowledge do on the patient satisfaction after treatment. So in conclusion, this study contributes to the early recognition of the most vulnerable patients. We also think that the results could be extrapolated to other departments or hospitals in the Western Cape that all struggle with also speaking patients and staff who don't speak it. And it also makes you think, how does it go in other provinces who also struggle with indigenous, in other indigenous South African languages. And I think it's this study only underlines the necessity of having a viable solution for the 11 official languages that are spoken here in South Africa and that contribute to a big language barrier. I want to acknowledge some people. First of all, Prof. Botha acting as my supervisor, and the registrars and interns who helped me with including patients. Also the nursing staff from F-Ground, J4 and the clinic, and also the translators that helped me, who made a big effort to make this all possible. Thank you for your attention. Questions?
Thank you, Yusuf. I think it's a very neat study. Yusuf presented this to us on Wednesday morning, and that's why he wanted him to present it to the department as well, because I think it will help us a lot in moving forward. So are there any questions to Yusuf?
Yusuf, in your model, only the language was significant in the regression model.
No,
the
sir.
other two were not significant. Education.
No, no. I didn't. Maybe I didn't explain that properly. All three variables were the model was the whole model that we made with the three variables was statistically significant.
Yeah, but
and
your R-squared there is 0.43.
Yeah, and the all three different variables were also statistically significant. But if you look in between the variables, so in between the groups, you can't say that this odds ratio is correct because it's statistically not significant. So what we only can really say about this odds ratio, about the odds ratio here, is that between high and low there is a significant odds ratio of 6.
But socioeconomic, as a contributor to your regression model, was
Yeah,
also significant.
it was also significant, yeah.
All
So
three.
All three were. Well, we actually used, I didn't, because that's a bit too far, we used a stepwise method. So that means each variable, dependent on its correlation, would be introduced to the model, with the highest correlation first and then the second. And until the model doesn't explain it is significant anymore. So what it actually did is eventually all three models fitted in, all three variables fitted in the model while still being statistically significant.
Any other questions?
Thank you, Yusuf. Just for everyone, I'm just a colleague of Yusuf visiting. I just want to know, you said that maybe a solution is adding causa to the MBCHB.
Yeah.
And I agree with you, but it would only then pertain to mostly to the Western Cape.
Yeah.
Wouldn't you rather think then adding a language course for the doctors at the hospital maybe would be a better solution where they're working?
Yeah, that's the most common answer I had actually on this solution is, yeah, but it doesn't matter because I'm gonna work in Limpopo later and they speak something different, and you're right, but while you're studying here, you also be in contact with patients, so.
Dia theta is causa. But I can honestly say to have a conversation in a native African language about cancer with a patient really requires a deep knowledge of the language. It's really, I can take a history from a patient, ask if you are coughing or have you got a running stomach and so on and so on. Have you got a fever? But that will really require a deep insight in the language. So I think probably for the time being and even in the medium term, probably the use of translators will be the best option. And I think the best people to use are actually the nurses, the oncology nurses, because they've got a lot of insight into the problem.
Yeah, but what I've noticed on the Wednesdays is that on Wednesday there's sometimes one nurse available who could do the translation, and then you're waiting so long till that nurse is available. And if you look at time is money, it would be better to invest in trained personnel.
It is a problem because we don't have a dedicated nurse in the clinic who can, who is fluent, as it was speaking. We used to have translators in the hospital, but that's disappeared many years ago. So in the past we could use the translators, but not anymore. So we will most likely use this to see whether we can get a translator service. And even if we have to pay for it just for a Wednesday afternoon, it might be very worthwhile for this group of patients. Kevin.
Thank you. It's actually very interesting because although this is pertaining to oncology, we could actually extrapolate this to basically the whole of our medicine, because in family planning, when we are counseling them on this type of issue, and if you ask them straight after you've explained it to them, they will tell you, actually, they're not sure what you heard. Also, with fetal medicine, for cases where you want to discuss termination, I mean, I've seen Prof do 25 minutes of counseling, and then straight afterwards, if you ask what was said, they will say they're not sure. And then we have to get a translator, and we have to do this whole thing again. So although we might need them for the oncology clinic, actually, if you look at it, you most probably need them for most of the clinics in the whole hospital, actually.
And there's no money for that. That's sad.
I think that's one of the reasons why Henny wanted Yusuf to present it, because he did it in the oncology population of patients, but as you correctly say, it's most likely also true for all of the other areas that we work.
The thing is, when I started this research, everyone I talked to said, "Oh yeah, it's a big problem." But if you asked, "Okay, but how big?" Nobody knows it actually. But it's just accepting the problem because it's that big. And I think this is a study that quantified that.
Just to say, we actually do have language as one of the subjects for the first year. We do Zulu, because that's the major there. I can tell you now, I don't remember a word, because the last time I used it was 9.5 years ago, because I studied at Wits. I haven't been in transportation, and no one did.
No.
So I don't think it'll work putting it into the curriculum, but like you said, maybe in the hospital, because that's where you're working, that's where it's going to be most effective.
Any other questions?